So let's start with pressure control of 10, and then a rate, we'll set a rate of 15, or a PEEP is 5, and in this case, because I'm only using 100%, I have to set my FiO2 to 100. And then I'll set a normal inspiratory time, and remember, this is pressure control, so there's a rate, and this is a mode, this non-invasive we might use for Mr. Smith, who's a frequent flyer. He's not intubated, but he's really not breathing, so we have to see if we can ventilate him reasonably until we decide whether we want to intubate him or not. Or maybe it was just a drug overdose and we don't want to intubate him. We know he's going to wake up after he gets some Narcan, so we just put him on this rate, assuming once again that we can effectively ventilate him. So we have an I time. And then the rise time, although we may not think about it a lot in invasive ventilation, it's something to consider a little bit more in non-invasive ventilation, and I'll explain when we turn the ventilator on and look at graphics why that might be important. You'll also notice that in non-invasive there is no sensitivity setting. There is no trigger setting. Okay? But there still is a trigger, and it's a pressure trigger. It's a negative pressure trigger. The reason there's no button there is the fact that, and let's go back to invasive ventilation. Let's say you had a patient that had a tube in, but the cuff was giving you problems, and you couldn't put any more air in it. And when it was in one position, the cuff leaked. So every time so consequently, what would happen to the ventilator? It would auto-cycle, right? So if it was auto-cycling because it was in this position, you'd have to go to the ventilator and make it a little bit less sensitive by turning the flow trigger from 5 down to 4 or 3 or 2, then it would stop cycling. Then when they moved him back to a different position, then it would be slightly harder for him to trigger, so then you'd have to turn the trigger back to a more sensitive setting. So what I'm describing to you is a dynamic change in terms of leakage where you're constantly having to adjust the trigger to try to keep them at the most sensitive but not auto-cycling point. Well, in non-invasive ventilation, we have that occurring all the time. Like with adults, when they're intubated, you don't have to worry about it because once you get the tube in, aside from some smaller percentage of patients, you don't have to deal with that leakage occurring. But with non-invasive, you're always dealing with some type of leak, and it's a variable leak. Sometimes it's a little bit, sometimes it's a lot. So the ventilator, recognizing that, rather than having you constantly adjust the sensitivity based on the amount of leakage that might be occurring at any particular time, the ventilator will automatically adjust that based on the amount of leakage flow that's occurring at any particular point in time. How much time, where are we with time? I don't...
This is over at 11 o'clock.
Oh, okay, right, so we're good. So that's why there is no sensitivity. It automatically adjusts its trigger point, and it's based on a negative pressure trigger. Okay. So once we have everything set, we touch accept. And in this case, we can touch and start ventilation, and initially we have this button, or this screen come up. Now, in the world of non-invasive ventilation, we have Mr. Smith here who's a little apprehensive and say, all right, Mr. Smith, we're going to be putting this mask on your face, so just breathe normally. We're not trying to suffocate you or do any harm to you. Just breathe normally. But yet when you're Mr. Smith and you see this mask coming, you get a little apprehensive. So before you get the mask and everything going, the ventilator allows you to deal with that and getting this all ready by going into what's called the waiting position. No alarms other than that air pressure that went off. No alarms, no blowing of gas, nothing going off. So now you have time to get things ready and to casually go and start ventilating Mr. Smith. Once you get an appropriate seal, the ventilator will recognize that and begin to ventilate. So now, in this case, if he's triggering the ventilator, he will trigger just like pressure control if you have a good seal and everything is reasonable with his seal. Now, one of the things that you mentioned early on about adjusting your settings initially is the fact that in non-invasive, the default parameter for the upper pressure limit is 20. And everybody is used to mostly invasive ventilation where the upper pressure limit default is 40. So one of the problems that you get into early on with non-invasive is, particularly in that apprehensive patient, is when you put the mask on, let's say you do set it at a pressure control level of 10. My PIP is only 16 now, which is not a problem, but if he's kind of struggling a little bit and pushing back, and he pushes back and it's easy for him to hit that upper pressure limit of 20. When that happens, he's thinking, you lied to me. You told me you weren't trying to suffocate me, but you are, and I'm trying to do everything I can to get this mask off. So he's fighting and all that because the ventilator keeps popping off, and you may think that it's auto-cycling, right? But it's really that the upper pressure limit is set too low. So my suggestion initially is to increase the upper pressure limit, and in non-invasive, the highest you can go is 40. So adjust it up to some higher level, right, to get the upper pressure limit away from wherever the patient is at that time, because then when he starts, you know, he's at least getting ventilated.
Gotta go higher, 100 at least.
Well, the only problem is you can't go any higher because the highest you can go is 40. That's the limit. You can't go any higher than that in non-invasive. Right. So that's why I say initially you have to start with a low pressure control level, right? So you start with low, because with non-invasive, if you need higher pressures than that ultimately, you know, after everything calms down, then the problem, you have greater problem with insufflation of gas into the stomach, and it's really not a good thing if you need higher pressures than 40 centimeters water pressure in non-invasive. So, but initially set your upper pressure limit away from where you might think your patient is going to end up or be. The other problem is that once, even if he's quiet, everything's working fine, you go, well, I need to get a proper volume coming back. Right now there's only 200 cc's coming back. I need to get, you know, more volume coming back. So you start to increase the pressure control level, and then you get to 15, but then you go to 18, 19. Right now, I'd be popping off if I hadn't hit it. And you go, what's going on? I just turned the pressure up. Oh, he's just getting excited, and, you know, it's auto-cycling, and oh, it's terrible, and so, you know, this isn't working, so let's intubate him. But the problem was that, you know, you forgot to turn this up initially, so right away it's auto-cycling, and the patient's freaking out because, you know, he's not getting a full breath. So that's why we have to move that away, okay? The other thing to keep in mind is what I alluded to here, the inspiratory rise. The inspiratory rise is, as we know, a feature that determines how aggressive, if you will, is one way to describe it, how aggressive the ventilator is going to be to deliver the breath, okay? And what it technically means is the inspiratory rise is set at 0.2 seconds, meaning that it's that the peak pressure, or the rise to peak pressure, is going to be delayed by 0.2 seconds. So the ventilator could get to peak pressure just like that if it wanted to, but we've told it to get there 0.2 seconds later. Okay? Now, if let's leave it at 10. If I set it at 0, it's going to get there as quickly as, I mean, just like that. So that means then, when we look at the waveform, when you look at the pressure waveform, the pressure curve goes up, straight up, okay? And so for a patient that's apprehensive, that may be, whoa, you know, I'm getting the flow too fast. In addition to the fact that I don't like this mask, in addition to the fact that the pressure is too great, it's also pounding me as hard as it can to get to that pressure point. So it may be helpful to increase your inspiratory rise to, let's say, 0.3 seconds. So when we look at the waveform now, we can see that the slant to pressure is a little bit, it's slanted compared to what it was. Right, rise over run, exactly. So now it's taking less or more time to get to the peak pressure. So in a way, there's less time because your eye time is still set for 1 second, but you're saying just get there a little bit later, and I know you're not going to be there for a total of 1 second anyway, but at least you get there later and the patient isn't freaked out by delivering all that flow. So one of the sayings that we came up with when we started doing non-invasive on the servo was we said, remember to set your ventilator up and remember the saying 30, 30, 30. 30, 30, 30. So in this case, there's only 2 30s, but I'll show you the next 30 when we go to non-invasive. But this is the first 30. The second 30 would be to set your upper pressure limit at 30 instead of the 20 that's the default value. And the last one would set your inspiratory cycle off when you're in non-invasive pressure support to 30% because the default value is 50%. You'll see that in just a minute. So those are the three little tricks that you have. In addition to the alarm package, if you have those patients that you still want a visual reminder that you're not effectively ventilating or that you may not be effectively ventilating, but it's become a nuisance and the nurses are going to kill you if you don't stop the ventilator from alarming, you have the ability to turn the minute volume, the respiratory rate, and the PEEP alarms off. So if you have that patient that's constantly fidgeting and the ventilator is, you get a respiratory rate because it begins to auto-cycle, because it auto-cycles for a minute, and I'll demonstrate that to you in a minute. It auto-cycles a little bit, or you lose the PEEP because the mask is a little bit leakier than it should be. His wife is there and it's going to fix it. At least you have a visual indicator because these alarms will visually flash, but it won't alarm. Okay? When you turn the bells off. Okay? And it tells you on the side of the ventilator, you see the PEEP over there, there's a little bell with an X through it, and the respiratory rate, a bell with an X through it, and the minute volume, and a bell with an X through it, so that somebody's turned those alarms off.